Okay, let's unpack this. Maybe you're gearing up for a big exam or, just need to get a handle on a complex topic fast. You've handed us these notes specifically on mumps, and our mission, well, it's to make this material really stick.
Yeah, like creating the ultimate sort of high-yield flashcards, but delivered as a conversation.
Exactly. So this deep dive, it's focused entirely on distilling your provided notes into the absolute essentials about mumps.
Uh-huh. What it is, how it spreads, what it looks like.
How you tell it apart from other things, and importantly, what can happen. And just to be clear, everything we talk about today comes straight from your material.
Right, your notes are the source.
So let's jump right into what your notes say mumps actually is. What's the core definition?
Okay, so it's a viral infection caused by the mumps virus, obviously. Your notes point out it's a notifiable disease in the UK.
Which tells us right away it's something public health tracks closely.
Exactly, and it's described as an acute infection caused by a Paramyxovirus, usually affects children and young adults.
And the bit everyone sort of knows about mumps.
That's its main target,
Yeah.
the salivary glands. It causes that, characteristic swelling and inflammation.
The puffy cheeks.
Right. But the notes quickly add a really critical detail. It can also impact other areas.
Wow.
We're talking testes, ovaries, even the central nervous system.
Okay, so right there, that sets the stage for why this isn't always just simple puffy cheeks.
Precisely.
How does this paramyxovirus get around then? What did your notes say about its spread?
Spread is via respiratory droplets.
Yeah.
Pretty standard for many viruses.
So coughing, sneezing.
Yeah. The path described is entry through the respiratory tract, then it replicates in those epithelial cells, and then it travels via the bloodstream to the parotid glands and potentially those other tissues we mentioned.
So you breathe it in, basically. And once you're exposed, how long does it take for things to show up?
Yeah.
And crucially, when is someone actually spreading it?
Well, the incubation period is typically 16, 18 days, so quite a while.
2 to 3 weeks, roughly.
Yeah. And the notes highlight your infectious from 1-2 days before any parotid swelling starts, right up to 9 days after it appears.
Wow, okay. That's a significant window where someone can be spreading it without even knowing they have that classic symptom.
That's a key point.
Interesting that people are contagious before the swelling. What were some other key points the notes made about the nature of this infection?
It's highly infectious, especially with close contact around the time symptoms start. And a key detail for revision, this is important, it can be asymptomatic in 15–20% of cases.
15 to 20%, so 1 in 5 might not even show symptoms.
Yeah, often in children, according to the notes. Usually getting it once gives you lifelong immunity.
Okay.
And the notes explicitly state the MMR vaccine wasn't just introduced to prevent mumps, but also specifically for monitoring it.
Right, makes sense for a notifiable disease. Okay, that's the absolute baseline. To make those core facts stick, based on your notes, maybe think of the 4 Ps for mumps basics.
Oh, I like that. What are they?
It's a paramyxovirus, primarily affects the parotid glands causing swelling, spreads via respiratory droplets.
Leading to Parotitis.
Yes. That's a useful way to consolidate those fundamental points, I think.
Definitely.
Moving briefly to etiology, what causes it? I mean, this really just reinforces the definition we just covered, right?
Exactly. Your notes confirm it's caused by the Mumps virus, part of the Paramyxovirus family, and the spread, like we said, respiratory droplets and direct contact with infected saliva.
Yeah, pretty straightforward there.
Mm-hmm.
So who's most likely to catch it, according to your material? What are the key risk factors mentioned?
Okay, the notes list the primary ones pretty clearly. Individuals who are unvaccinated or incompletely vaccinated are most vulnerable.
Makes sense.
Also, people in crowded environments, think university dormitories, that kind of thing, and those involved in close contact activities.
So we could maybe think UCC for risk factors, straight from your notes.
Yeah.
Unvaccinated, crowded environments, close contact.
UCC. Yeah, simple and memorable.
Now, how does the virus actually do its damage inside the body? What's the pathophysiology described in the notes?
Okay, your notes explain that the virus specifically targets the salivary glands. That targeting is what leads to the inflammation and swelling we see.
Got it.
It gets in via the respiratory tract, replicates there, and then spreads systemically through the bloodstream to reach those target glands and potentially other sites too.
Okay, entry, replication, spread, target. Simple enough. Now, this next section is absolutely critical for revision, especially in a clinical setting. Differential diagnosis.
Oh yeah, definitely. If someone shows up with symptoms that might be mumps, what else could it be? based only on the possibilities listed in your notes, of course.
This is vital. Your notes group these quite well, actually. First, think about other causes of salivary gland swelling. What's on that list?
Right, so the list includes bacterial silodenitis, certain autoimmune diseases, and other viral infections. Specifically named are Epstein-Barr virus, EBV, and cytomegalovirus, CMV.
So, yeah, a swollen cheek doesn't automatically scream mumps.
Precisely. Although the notes do emphasize that the parotitis itself, the tender, swollen parotid glands, is a distinctive feature of mumps.
Okay, so that's still a key pointer.
It is.
Ugh.
But beyond just the swelling, your notes list other considerations. These are conditions that might mimic mumps or its complications.
Like what?
This includes HIV infection or something like a parotid duct stone. The notes actually mention that's more common in older patients. And importantly, symptoms often worsen with chewing.
Oh, that's a useful clinical detail to distinguish it. The timing with chewing.
Yeah, that context for the duct stone is a key point from the notes.
What else is on that other considerations list?
Viral meningitis and encephalitis are there, which, mumps can cause, but they also happen independently from other causes.
Right.
Mumps is specifically listed too, and the notes stress differentiating it from testicular torsion. That's crucial because torsion is a surgical emergency.
Absolutely critical distinction. Anything else?
Rubella is also mentioned, along with drug and allergic reactions that could potentially cause swelling.
Okay, let's try to make this practical, strictly using your notes. If you're presented with a patient, say, unilateral parotid swelling and a fever, what are the absolute must-consider diagnoses from this list, besides mumps itself?
Okay, based only on this list from the notes, you immediately need to think about bacterial salidinitis, those other viral causes like EBV or CMV. And if it's appropriate for the patient's age and history, consider that parotid duct stone, especially noting if the swelling changes with eating, like the notes pointed out.
That's a great way to apply the differential list from your notes. Good. Moving on, where and when do we typically see mumps based on the epidemiology section?
Well, as a notifiable disease, cases are tracked. And yes, cases are still reported even with the vaccine. The notes point out that outbreaks tend to happen in communities with lower vaccination rates.
That makes sense.
Your notes also give some historical context. A significant decline after the NMR vaccine was introduced in 1987.
Right.
But they also highlight recent cases linked specifically to university settings.
That connection to universities is a very specific detail from your notes, definitely relevant today. Now let's talk about what mumps actually looks like in a patient. What are the clinical presentations described?
Okay, the common signs and symptoms listed are, well, the painful swelling of the parotid glands, typically near the ears,
Right.
along with fever, headache, muscle aches, fatigue, and loss of appetite. Sort of flu-like symptoms plus the swelling.
Let's get into the details of that parotid swelling. Your notes seem quite thorough on this.
They are. Initially, it's often unilateral, just one side. But your notes state it becomes bilateral in about 70% of cases.
70%. Yeah.
And interestingly, those non-specific symptoms we mentioned, fever, headache, malaise, myalgia, anorexia, they can actually start before the parotid swelling even appears.
Wow, the prodrome.
Exactly. The fever can be quite high, notes say up to 39.5 degrees C in small children. The swelling itself can distort the face and neck, and the skin over the area might look hot and flushed.
And severe swelling.
Severe swelling, your notes mention, can actually obstruct mouth opening or cause dryness because the salivary ducts get blocked.
Okay.
And while the parotid is the primary target, the notes add that submaxillary and sublingual glands can also be involved, though apparently that's rare.
So the swelling is the most visible part, but it's part of a broader picture. What about the involvement of other body parts? Your notes really focus on orchitis, the testicular inflammation.
Yes, that's a significant complication detailed here. Orchitis can occur about 4 to 5 days after the parotid swelling has started.
Okay.
Or, importantly, it can occur without any parotitis at all, so someone could just present with testicular pain as their main mumps symptom.
Wow, okay. And the symptoms of orchitis itself.
Symptoms include chills, sweats, headache, backache, and crucially severe local testicular pain and tenderness.
How does it present visually, according to the notes?
The notes describe the scrotum as swollen and edematous, sort of fluid-filled and puffy, sometimes making the testes difficult to actually feel because of all the swelling.
And is it usually on both sides, or just one?
Your notes say it's usually unilateral, so one side, but it can be bilateral or even alternate sides. It affects around 25% of postpubertal men.
1 in 4, roughly. That's quite high.
It is. But a reassuring detail noted is that subfertility following bilateral orchitis is actually rare. That's a key point for counseling based on this material.
That is important to know. What about the nervous system involvement you touched on earlier?
Right. Your notes state mumps can affect the nervous system. Meningism, the symptoms like neck stiffness and light sensitivity, but without full meningitis is noted in about 15% of patients.
15%.
And crucially, your notes mention this can happen without the parotitis.
Again, mumps without the classic swelling.
Exactly. If it progresses to full meningitis, it's usually mild and self-limiting, according to the notes. Encephalitis, which is more serious brain inflammation, may occur early after the infection or sometimes as a post-infectious event.
Okay, that gives a pretty comprehensive picture of what to look for. To help remember the common symptoms from your notes, maybe think swell.
Swell. Okay, let's hear it.
Swelling, parotid, weakness, fatigue malaise, elevated temp fever, low appetite, limb muscle aches.
Swell. I like it.
And maybe remember to add other body parts mentally for the orchitis and nervous system involvement, which your notes detail quite a bit.
Good mnemonic. So how do we confirm mumps then, based on the investigation section of your material?
Your notes make a really important point here. They say while clinical diagnosis used to be common, laboratory confirmation is now required.
Ah, okay. That's a key shift in current practice based on these notes. Why the change, do they say?
They don't explicitly state why, but you could infer it's likely because with widespread vaccination, maybe atypical cases are more common. And it's essential for accurate public health tracking and distinguishing from other causes.
Makes sense. So what are the confirmation methods listed?
Serologic testing looking for mumps-specific antibodies or detecting the viral nucleic acid using PCR.
Antibodies, or PCR. Standard virology stuff. Are there any specific testing nuances mentioned?
Yes, your notes mention that if you suspect mumps meningitis but there's no parotitis, you can still detect serum mumps-specific antibodies.
Useful.
And for vaccinated patients, the notes say real-time reverse transcriptase PCR and mumps genotyping are particularly useful techniques.
Okay, more specific tests for trickier cases.
And going back to the testicular pain for a second, is there a specific investigation mentioned for that? To differentiate it?
Absolutely. And this is a high-yield detail from your notes for telling apart emergencies. High-resolution color Doppler ultrasound. It can differentiate mumps orchitis from testicular torsion.
Right, that's that critical point for clinical assessment, ultrasound for the testes.
Definitely.
Okay, so for investigations, maybe think LNA for confirmation, highlighting the now required aspect, lab confirmation needed now, antibodies, serology, blaster, PCR.
Lab blaster. Catchy.
And don't forget ultrasound, especially crucial for the gonads based on your notes.
Got it. Ella Blafter and ultrasound. So, once it's confirmed, what does your material say about managing mumps? Is there a cure?
Your notes are very clear on this. There is no specific treatment for the mumps virus itself. The focus is purely on symptom relief, supportive care.
Okay, so what does that supportive care involve?
Pretty much what you'd expect.
Yep.
Rest, pain relief. The notes specifically mention paracetamol, hydration, and isolation, obviously, to prevent further spread.
Makes sense. And of course, your notes circle back to prevention with the MMR vaccine.
Always. So supportive care while the body fights it off. What about the typical outcome, the prognosis? What do the notes say?
Generally good, according to your notes. Most individuals recover within a few weeks without serious problems.
That's reassuring.
However, the notes do precede the complications list by mentioning that rare ones can occur, and they give a specific, quite sobering number for a severe complication.
What's that?
1 in 1,000 patients with mumps meningitis can develop fatal encephalitis.
1 in 1,000. Wow. That really puts the potential severity into perspective, even if rare.
It does.
So let's dig into that complications list your notes provide. What are all the potential issues detailed there?
Okay, the ones most frequently discussed are orchitis in postpubertal males. Your notes give a prevalence of 25–35%.
We covered.
Right.
Yeah.
And oositis, which is inflammation of the ovaries, in postpubertal females. Hearing loss is also listed as a significant complication.
How significant?
It's described as usually unilateral and often transient, so temporary, but your notes provide specific rates for permanent deafness. About 4% total deafness in affected ears generally, and specifically 1 in 20,000 cases resulting in permanent deafness overall.
1 in 20,000 permanent deafness. That permanent hearing loss figure is particularly impactful from your notes.
It really is. Other potential complications listed include meningoencephalitis, which we touched on,
Mm-hmm.
pancreatitis, and then a list of less common ophiritis conditions: neuritis, arthritis, nephritis, thyroiditis, and pericarditis. Quite a list.
That's a lot of potential inflammation spots. What about mumps during pregnancy? Do the notes mention that?
Yes, your notes state that mumps during early pregnancy may increase the risk of abortion. But, and this is important, it explicitly states, it is not considered teratogenic.
Meaning it doesn't cause birth defects.
Exactly. That's an important distinction from your material.
Okay. Any final prevention points mentioned in the complications section itself?
Yes, your notes just reiterate prevention measures there:
Mm-hmm.
MMR vaccine, good hygiene, and isolation. The standard public health advice.
Right. Okay, let's try and wrap up those complications with a memory hook from your notes. Maybe think mumps can hurt other parts.
Okay. MCHOP.
Meningoencephalitis. Complications include hearing loss, orchidosophoritis, pancreatitis.
MCHOP mumps can hurt other parts. I like it.
And then you just have to remember to mentally add the specific aphitis conditions listed in your notes: neuritis, arthritis, nephritis, thyroiditis, pericarditis, and that detail about the pregnancy risk.
That effectively covers the comprehensive list from the material, yeah.
Yeah. And here's where it gets, I think, really interesting and highlights the value of going through these notes so thoroughly. Despite sometimes being dismissed as, just a simple childhood illness prevented by vaccination.
Right.
Look at that potential list of complications your notes provide, from temporary discomfort to permanent deafness or that rare but potentially fatal encephalitis.
Yeah, it's quite sobering when you lay it all out.
This deep dive using your notes really underscores why vaccination programs are so vital and why it's crucial to recognize the varied ways mumps can present and the risks it carries, even today.
It definitely shows it's a lot more than just a childhood nuisance in many cases. Absolutely.
So we've navigated through the definition, how it spreads, who's at risk, how it affects the body, what else could mimic it,
The differential.
where and when it appears, what it looks like clinically, how to confirm it with labs, how it's managed, the typical outcome, and that whole range of potential complications.
All strictly pulled from the material you provided.
Exactly. Hopefully, breaking it down like this, section by section, highlighting those key details and memory hooks directly from your notes, makes this topic feel much more digestible and, high yield for your revision.
Yeah, it got the core facts, the distinctive features, those memory aids. Hopefully it helps recall the specifics under pressure.
Absolutely. Now, the best step is probably to go back through your original notes, see what stands out to you now after hearing it broken down like this.
Maybe quiz yourself specifically on those differential diagnoses or the details about the complications we pulled out from the notes.
Put that knowledge to active work. Make it stick.
Definitely.
And if you're looking for even more resources to help you prepare, you can check out passthemsra.com.
And for a fantastic free resource, don't forget freemsra.com.
Wishing you the very best with your revision.